Yeah. He also holds an appointment as clinical associate professor at the University of Sydney and has published more than 60 peer-reviewed articles in the fields of neuroimaging and neurovascular and cardiovascular imaging. He is a founding member and the current president of the Spain Society of Pediatric Neuroimaging. And today, he'll be taking us on the topic cerebellar and brainstem malformation. And this talk will present a pattern-based framework for approaching cerebellar and brainstem malformations of MRI, starting with the normal posterior fossa anatomy and the distinction between dysplasia, hypoplasia, and atrophy, then moving on to the diagnostic algorithm built around cerebellar involvement, cysts, brainstem morphology, corpus callosum, basal ganglia, and context. So teaching cases will cover the Walker malformation, Blake pouch cyst, thromboencephalosynapsis, Joubert syndrome, and related cerebropathies, pontocerebellar hypoplasia, tubulinopathies, and axonal guidance disorders, including horizontal gaze palsy with progressive scoliosis and tegmental cap dysplasia with reference to current genetics literature throughout. Join me as we welcome Dr. Robert Goetti to take us on this presentation. You're welcome, sir. You have the floor.
Thank you very much, Ayamita. Thank you for the kind introduction. And also, Adesola, thank you very much for the invitation to speak today. I understand it's still afternoon in Nigeria where you are. It's 11 p.m. here in Sydney. I will spend approximately the next 45 minutes talking to you about cerebellar and brainstem malformations. As you might hear, I have a bit of a cold, so please apologize if I will need to have a small cough in between. Anyway, the outline of my talk we will start looking at the posterior fossa, the normal cerebellum and normal brainstem, because we need to determine what is normal before we can see what is pathological. We'll look at definitions of cerebellar dysplasia, hypoplasia, and atrophy. And then we'll move on to a diagnostic approach, first looking at cerebellar atrophy, and then also at hindbrain malformations. And along the way, I will show you several examples of malformation, specific malformations with unknown or uncertain genetic causes. So first question we have to ask ourselves is the posterior fossa normal? And I like to use these landmarks. So the incisura line, which is a line that is drawn from the dorsum sellae through the incisura of the tentorium, should approximately go through the middle of the midbrain. If we draw a parallel line to this incisura line at the sphenooccipital synchondrosis, this should be about halfway between the incisura line and the basion. So the occipital portion of the clivus and the sphenoid portion of the clivus should have a similar length, and this should go about through the middle of the pons. A line at the basion, also parallel, should go through the obex. So these three lines should basically intersect our midbrain, our pons, and then into the medulla. The Chamberlain and McRae's line should be approximately in a similar plane. I also like to think of the posterior fossa as a pentagon on the sagittal view. This pentagon, when drawn from the basion to the dorsum sellae, so along the clivus, then along the incisural line, from the incisura to the torcular, and from the torcule to the opistheon, should give you a pentagon which is fairly symmetric and regular. Will never be perfectly regular, but you can see it as a fairly regular pentagon. I'll show you two cases where this is abnormal. So the first patient here has a Chiari-1 malformation. The Chiari-1 malformation is not a malformation of the brain, it is a malformation of the skull base. So basically it means that the skull base hasn't formed into a size that can accommodate the entire hindbrain. And in this case, particularly, you can see the reason for this is there is a short clivus. So from this, if you look at the pentagon, the clivus is very short. The foramen magnum is not narrowed, and we can see the cerebellar tonsillar descent. The second patient here has achondroplasia, And he also has a very short clivus, as you would expect in achondroplasia. But additionally, there's also a very short line from the basion to the epistion. So there's a narrowing of the foramen magnum. And in this case, the problem is not a Chiari malformation. In this case, it is the narrowing of the foramen magnum, which can lead to compression at the cervicomedullary junction. You can see in this case also that this incisural line does not intersect the midbrain, it intersects the pons. So the posterior fossa is too small for the brain. Here is another example of an abnormal posterior fossa, and this patient has a Chiari 2 malformation. Here, the clivus is not short. The problem in this case is that the posterior fossa never properly expanded. The Chiari 1 malformation, as I mentioned before, is a primary skull-based problem. So we have a basio-occipital hypoplasia. The problem is a mesodermal origin of the skull base. It is not a CNS malformation. The Chiari 2 malformation, on the other hand, is an issue of the posterior fossa not forming properly because there is a CSF leak elsewhere. So the Chiari 2 malformation develops due to an open spinal dysraphism and can be thought of as an antenatal form of intracranial hypotension. So now that we've looked at the normal posterior fossa, we'll have a look at the normal brainstem and the normal cerebellum. When we look at the proportions of the brainstem, I find it's easiest to remember that the midbrain should be about half the height of the pons, and the medulla should also be about half the height of the pons. The actual exact value is about 1.8 rather than 2 times, but I think 2 is close enough for just sort of an eyeballing approach. The dorsal aspect of the pons, so the tegment, should be flat, so it should not be concave or bulging. We'll look at different cases where that is not present. And the vermis should extend from the inferior colliculi to the level of the obex. The superior and inferior vermis should be roughly symmetrical. The fourth ventricle should form a tent with an acute vestigial angle, so the angle from the upper part of the fourth ventricle and lower part of the fourth ventricle leading to vestigial point should be an acute angle. On axial views, we can see the nice sort of onion layer appearance of the cerebellar folia. And if we do DTI, we can see coded in blue, which is craniocaudal encoding, the corticospinal tracts anteriorly, the medial lemnisci, transverse pontine fibers, and the cerebellar peduncles. When it comes to the size of the cerebellum, the height of the vermis from about 5 years of age is relatively stable, between 4 and 5 centimeters, and the AP diameter is also fairly stable after 5 years of age, between 2 and 3 centimeters. What, however, is really important to remember is that the vermis and the entire cerebellum is still undergoing rapid growth during the first 2 years of life. You can see these on these charts. So basically, the normal range goes from 2 centimeters to 4 centimeters within a year, so double the height. AP diameter of the pons should conveniently also be about the same as the double the AP diameter of the medulla. The reason I mention the rapid growth of the vermis is that it's important to recognize that in neonates, the posterior fossa may look a little bit too big. So this term neonate and this 1-year-old both have a normal cerebellum. In the term neonate, the cerebellum looks relatively small for the posterior fossa. You could be inclined to potentially call this a megacisterna magna. It's a term that I don't often use because I find it's not very helpful. But ultimately, the cerebellum is still growing into the posterior fossa. And we can see on this graph that between birth and 400 days of age, so a little over a year of age, the proportion of the cerebellar volume as a proportion of the entire intracranial volume increases from under 7% to almost 11%. So there's a rapid growth of the cerebellum. So be wary of overcalling cerebellar hypoplasia in neonates. If in doubt, you can always use reference values and measure the cerebellum. This is even more important when you deal with premature infants because between the 24th and the 40th week post-conception, the cerebellar volume increases 5-fold. As a sort of a rough rule of thumb, you can measure the transcerebellar diameter, and that should be about the same as the gestational age. So at a gestational age, of 30 weeks, the transcerebellar diameter is about 3 centimeters, and at a gestational age of 40 weeks, it's about 4 centimeters. It's not exactly perfect, but that's sort of a rough rule of thumb that you can orient yourselves on. So now that we've looked at the normal posterior fossa and the normal cerebellum and brainstem, we want to start defining our abnormalities. So first up, we want to differentiate between dysplasia, hypoplasia, and atrophy of the cerebellum. Cerebellar dysplasia is a non-progressive morphological abnormality, whereas cerebellar hypoplasia is a compact cerebellum with a reduced volume but a normal shape. Cerebellar atrophy, on the other hand, is an initially normal cerebellum in a normal posterior fossa, which shows enlarged fissures due to volume loss. Now, it can be quite difficult to differentiate between cerebellar hypoplasia and cerebellar atrophy, specifically if you only have one scan. So it may be necessary to do a repeat scan to see if the atrophy increases. And the atrophy is shown by enlarged fissures. So this patient with a small cerebellum, fissures are not as wide as in this patient with cerebellar atrophy. When we look at different patterns of cerebellar atrophy, the most common pattern has been termed the butterfly pattern. And it's termed that because in the butterfly pattern, we have an involvement of the vermis more than the hemisphere. So looking like a butterfly, small body, big wings. When we have the inverse of that, so when we have an atrophy that involves the cerebellar hemispheres more than the vermis, this has been termed the dragonfly pattern. This is less common, and because it is less common, it can help us determining what the potential causes could be. So some of the causes of a dragonfly atrophy are certain types of PCH, specifically 2A and 9, some cases of neuronal ceroid lipofuscinosis, and also extreme prematurity. When we have asymmetric cerebellar atrophy, this is usually an acquired and not a genetic cause. There are some genetic causes that can lead to cerebellar insults, such as amplius COL4A1 mutations, but generally it's an acquired cause if it's asymmetric. And here's an example. So this is a patient with a presumed antenatal insult. When you see a cerebellar cleft, the rest of the cerebellum looks completely normal, but you see a cleft, have a look at this SWI or a gradient echo sequence and see if you can find any evidence of hemorrhage, because quite often you will find little foci of residual hemosiderin, and that will help you determine that this was an antenatal insult that led to a cerebellar cleft rather than a genetic abnormality. So now we want to determine in a patient with cerebral atrophy whether it is hereditary, so genetic, or if it is acquired. The diagnostic approach is not just based on imaging. First and foremost, we need to have a good history. So you need to speak to neurologists, your pediatricians. You need to know, is there a history of prematurity? Has there been any insult? Does the patient have epilepsy? Because epilepsy itself can lead to cerebellar atrophy, and treatment with anti-epileptic drugs can lead to cerebellar atrophy. Obviously, if there has been surgery or radiation, is very important to know. The age of onset can be very helpful. So if the onset is fetal or neonatal, then typically this is a pontocerebellar hypoplasia. We'll talk about this in a little later. And if the onset is later, you can have different infantile, juvenile, and adolescent form of metabolic disorders. So it can be helpful to know at what age the onset of the atrophy was. What can also be helpful is to determine the time of the onset of the cerebellar atrophy compared to other findings. The pattern of atrophy, which we spoke before, is the vermis or the hemisphere more involved? Is it asymmetric? The severity of atrophy, and for a radiological perspective, most importantly, are we looking at just cerebellar isolated atrophy, or do we have cerebellar atrophy with other MRI findings? So what are common causes of hereditary cerebellar atrophy? These causes will vary quite substantially depending on where your practice is. So I would assume that the genetic causes of cerebellar atrophy in Nigeria will probably be different than the ones in Toronto, just because of the different genetic makeup of the population. Many of these are autosomal recessive. Overall, we can say that the majority of causes for hereditary cerebellar atrophy actually are mitochondrial disorders as a group. In this large cohort in Toronto, the second most common were neuronal ceroid lipofuscinosis, followed by several other ones. Now, what's important to remember is we speak about genetic testing a lot, and even with genetic testing, a final diagnosis was only made in less than 50% in this cohort. This was an older cohort from 2012, but even in a more recent study from 2020, where they looked at 184 adults with presumed hereditary cerebellar ataxia who underwent whole exome sequencing, they only found an actual genetic cause in 47% of cases. So even if you do have access to genetic testing, it will only give you an actual answer in less than 50% of the cases. This is why we have to consider our MRI phenotype and the clinical phenotype. For isolated cerebellar atrophy with any other findings, this was a study of molecularly diagnosed families. And here the channelopathies were the most common, also again followed by mitochondrial disorders. What's interesting to see is that the three most common genes for isolated cerebellar atrophy in this series were CACNA1A, KIF1A, and ITPR1. So CACNA1A and ITPR1 are both calcium channels, and KIF1 is a microtubule-directed motor protein. The reason I'm showing this a little bit busy slide is that for all of these different genes, there are also different clinical phenotypes. And most prominently, if you look at CACNA1A, some patients will present with developmental and epileptic encephalopathy. Some will present with episodic ataxia, some with familial hemiplegic migraine, and others with spinocerebellar ataxia. So all of these patients will show only cerebellar atrophy on the imaging. They will all have a mutation in the same gene in a different location, but they can present with completely different clinical phenotypes. So it's really important to look at the phenotype and the MRI and trying to figure out what is going on with the patient. Now, as radiologists, the best thing we can do is try and find associated findings. Now, if we have cerebellar atrophy, we want to look for white matter abnormalities. We want to see if there is hypomyelination. So for hypomyelination, there's a differential list. We want to look if there are progressive white matter lesions. In those cases, we'll be thinking about leukodystrophies, mitochondrial disorders, lysosomal storage disorders. Next, we're going to look at the basal ganglia and thalami, specifically are there basal ganglia lesions or calcifications. So if there's lesions or calcifications, we'll be thinking again of mitochondrial cocaine syndrome, infantile neuroaxonal dystrophy, Wilson's disease, and potentially interferonopathies, such as Aicardi-Gutierrez syndrome. What I do want you to remember, this is quite a busy slide, but what is really valuable to remember is the T2 hypointense thalami. If you have hypointense thalami on T2, that will be a strong indicator that the underlying problem is a storage disorder. And that can be either neuronal ceroid lipofuscinosis or other lysosomal storage disorders. Then we also want to look at the pons and cerebellar cortex. If the pons is bulky, there's really only one major differential, which is RSAX, and if it's atrophic, then we're thinking about PCH. For cerebellar hyperintense cortex, this was originally described to be pathognomonic for INAD. However, as in so many cases where things were described as pathognomonic, then later on we found out there's a bunch of other diseases can have the same appearance, such as mitochondrial, Marineschke-Srögen, Christian syndrome. So let's go to a few examples. So this is a 16-year-old girl with progressive ataxia. She also had intellectual disability and delayed menarche. What we can see on the MRI is that she has quite severe cerebellar atrophy. So you can see the cerebellar fissures are enlarged. Apologies. On the coronal view, you can also see how the fissures are enlarged. But in addition to the cerebellar atrophy, she also has abnormal white matter signal. And this is a T1 weighted sequence, and this is a T2 weighted sequence. And you can appreciate that her myelination looks abnormal. So her myelination looks like that of an infant, although she's 16 years old. So this patient has presented with hypomyelination, cerebellar atrophy, and these clinical symptoms. Hypomyelination cerebellar atrophy has a fairly wide differential, as you can see here. But again, if we include clinical information of the delayed puberty, we end up with a specific diagnosis. And the diagnosis in this case is 4H, which stands for hypomyelination, hypodontia, and hypogonadotropic hypogonadism. This is the second most common hypomyelinating entity after Pelizaeus-Merzbacher disease and is caused by recessive mutations in either pol R3A or pol R3B. Clinical presentation can be quite variable, but the main finding on MRI is the hypomyelination and the early cerebellar atrophy. Here we have a different case of a 2-year-old girl with seizures and alternating exotropia. In her case, she only had mild cerebellar atrophy. What we can see and developmental regression, this is an important finding. So if you have developmental regression rather than just a static developmental abnormality such as CP, if you have regression, you need to think about neurodegenerative disorders. And in her case, she did have mildly hypointense thalami. So here's a close-up, and you can see the thalami are just a little bit darker than the rest of the basal ganglia. This is a normal patient. Now, CLNs, for short, are a quite heterogeneous group of storage disorders, and collectively, they're actually the most prevalent neurodegenerative disorders of childhood. Some of these can be treated with recombinant proenzymes, and for this reason, it is good if we can recognize it early. And again, the main finding is T2 hypointense thalami. Here is another case of a patient with a different entity called infantile neuroaxonal dystrophy. This is caused by a PLA2G6 mutation and is also known as neurodegeneration with brain iron accumulation type 2A. So PLAN, not PCAN, which is neurodegeneration of brain iron accumulation type 1. So in this patient, we will have cerebellar atrophy. Sometimes there will be clava hypertrophy, so hypertrophy of the obex here. And what we can also see in this patient is the low T2 on the globi pallidi. This is a B0 image from the diffusion weighted imaging, and you should not have iron accumulation at this young age, and that will lead us to a diagnosis of INAD. So now we've looked at a whole bunch of different cases of cerebellar atrophy. So now I would like to move on to hindbrain malformations. When we talk about hindbrain malformations, we can also have a specific approach to these. I like to start with the pattern of the cerebellar involvement. So in this case, we have a malformation of the cerebellum where the vermis is absent and both cerebellar hemispheres are fused. And this is known as a rhombencephalosynapsis. It is very stereotypical, and there is probably an underlying genetic cause that just hasn't been identified yet. Recurrence has only been reported in 2 families, so the underlying genetic cause is probably a sporadic autosomal dominant mutation. There is no evidence for extrinsic factors contributing to rhombencephalosynapsis. The next thing you want to look for is cerebellar cysts. And cerebellar cysts can be quite helpful for your differential diagnosis because there aren't very many entities that cause cerebellar cysts. And this is one of them. In this patient, we have cerebellar dysplasia. You can see the folial pattern is abnormal here in the vermis, but also in the cerebellar hemispheres. And there are multiple small cerebellar cysts. There were no supratentorial abnormalities. And a patient with cerebellar dysplasia with cysts and no associated supratentorial abnormalities, your most likely diagnosis is going to be Poretti-Boltzhauser syndrome caused by a mutation in the LAMA1 gene. There are other diseases that can cause cerebellar cysts. However, in these cases, there are also associated supratentorial abnormalities. So in the ADGRG1 mutation, we also have cerebellar cysts, but in this case, we'll also have bilateral frontoparietal polymicrogyra or cobblestone malformation and very abnormal white matter signal. And in dystroglycanopathies, we have cerebellar cysts, and in the Walker-Wallenberg syndrome, which is one of the dystroglycanopathies, you get this characteristic Z-shaped brainstem. They will also have a supratentorial cobblestone malformation. It's important to remember with the dystroglycanopathies, they will often also have involvement of the muscles and the eyes, and one of the milder forms is consequently called muscle eye brain disease. Moving on, this is a little excursion to posterior fossa cysts. So these are not cerebellar cysts, but I'm mentioning this because it's an important thing. So we have three different patients here. The first one has an arachnoid cyst. In this case, we have a cyst, but the vermis is normal. The vermis in this case is compressed, but it is morphologically normal. The posterior fossa can be normal or small, depending, it could be normal or large. Some of these can cause some scalloping of the posterior fossa, but there's not a morphological abnormality of the vermis. There is usually not hydrocephalus, but sometimes we can see hydrocephalus if there is a lot of mass effect. The second patient has a Blake pouch cyst. He also has a normal vermis. He has a cyst communicating with the fourth ventricle. Usually the posterior fossa is normal, and usually there's a hydrocephalus. So the Blake's pouch cyst can be thought of as a obstructive hydrocephalus with an outflow obstruction at the foramen magendi, and I will explain this in a bit more detail in a second. The third patient here has the classic Dandy-Walker malformation, where we have an hypoplastic upturned vermis, cystic enlargement of the fourth ventricle, and an enlarged posterior fossa. Now, the Blake's pouch cyst, as I mentioned, is actually caused by failure of perforation of the foramen magendi. So the posterior membranous area will form the Blake's pouch, which is a transient structure. And when this perforates, we have the foramen magendi. If this fails to perforate, you get the Blake's pouch cyst. Now, in this drawing, you can see the choroid plexus is above the Blake's pouch cyst, and that's important to remember for differentiating from the Dandy-Walker malformation. So when we have the Blake's pouch cyst that expands, it will push the vermis and upwards, and it will also push the choroid plexus upwards. The Dandy-Walker malformation was first described but not named so by Dandy and then in 1921 and then Walker in 1942, and the term was coined by Benda in 1954. Dandy actually thought that the Dandy-Walker malformation was caused by an atresia of the foramen magendi, so he basically thought it was a Blake's pouch cyst, and Benda thought it was a form of rachoschisis. So they were all incorrect, but they still carry the name. The Dandy-Walker is actually caused by an insult to a transient structure called the rhombic lip before the 14th postconceptual week. And this can be either due to a vascular or other extrinsic disruption. So this rhombic lip it has an insult, and that is what causes the Dandy-Walker malformation. The Dandy-Walker malformation, because of this abnormality of the cerebellum, will lead to an obtuse vestigial. There's the classical finding of the molar tooth sign on MRI. It is characterized by thick horizontal superior cerebellar peduncles and a deep interpeduncular fossa, giving this molar tooth appearance. Also, will have a dysplastic or hypoplastic vermis and an elevated vestigial point. And this molar tooth is the defining factor for Joubert syndrome and related disorders, JSRD. So this diagnosis is defined by the MRI finding. Now, sometimes we can have a finding that is not a classic molar tooth. So you probably wouldn't necessarily call this a molar tooth, but you can see on the sagittal, the vermis does have this appearance that we typically see in Joubert syndrome. And in those cases, diffusion tensor imaging can be helpful. So in a normal diffusion tensor imaging at the level of the superior cerebellar peduncles, you should see this red dot. As I mentioned earlier, red encodes left-right, so these are transverse fibers, and this is the decussation of the superior cerebellar peduncles. In a patient with Joubert syndrome, this red dot will be missing, and we will just have the thick superior cerebellar peduncles, green for AP, no red crossing fibers. We can also have a asymmetric molar tooth, so where we have a molar tooth sign and an abnormal pons, and this has been termed a decaying molar tooth and is also a part of the molar tooth spectrum and also defines Joubert syndrome. So Joubert syndrome, as mentioned, is defined actually by the MRI finding, and there are more than 40 genes that can cause it. It is a ciliopathy, and there's quite substantial overlap with other ciliopathies. The patients can have renal, hepatic, retinal, or skeletal findings. And the patient, even patients with the same genetic mutation, can have different phenotypes, and which support the existence of some genetic modifiers in these diseases. This next patient, I did not know this diagnosis when I first saw them. I assumed that they had some sort of perinatal or antenatal insult. You can see supratentorially there is a lot of white matter volume loss. It almost looks like PVL. There are hypoplastic or atrophic basal ganglia. There's a really thin, if not absent, corpus callosum. If you look at the cerebellar vermis, the vermis actually looks normal, but the cerebellar hemispheres are small. And you can almost see here where the normal outline of the cerebellar hemispheres should be. So this is the dragonfly pattern of cerebellar atrophy. You can see also the pons is very small. So in this case, we are actually dealing with a form of pontocerebellar hypoplasia. So what is pontocerebellar hypoplasia? This was originally described in 1993 as two types, and they are both actually autosomal recessive neurodegenerative disorders with antenatal onset. So pontocerebellar hypoplasia is actually a misnomer. It should be pontocerebellar atrophy because it is progressive. Now, currently we have 13 plus subtypes that have the label PCH, and most of these are due to genes involved in RNA processing with unclear exact mechanisms. But there are also many other phenotypes of pontocerebellar hypoplasia that do not carry this label. There's a nice study by Rusch and others in the Cerebellum from 2020, which I like to consult when I come across these cases. And they've looked at the associated infratentorial and supratentorial abnormalities. So in our case, and you can see all the different PCH subtypes, you can see other diseases that can look like PCH but aren't called PCH. And when we look at the dragonfly pattern, that already narrows it down quite substantially to a few forms of PCH and the disruption of prematurity, which I mentioned earlier. Now, if we also see that the patient has agenesis of the corpus callosum, this actually narrows us down to PCH type 9, and this is exactly what this patient had. So this is a very characteristic appearance of PCH type 9, where you have the supratentorial PVL-like appearance, you have a dragonfly atrophy of the cerebellum, and you will often have this figure 8 midbrain as well. The next patient is a 1-year-old boy with horizontal gaze palsy and scoliosis. And as I mentioned previously, the clinical presentation is important because in this case, the clinical presentation of horizontal gaze palsy and scoliosis is the diagnosis. So what are the findings on MRI? On MRI, we can see that the tegment of the pons is not flat like it should be, it is concave. And the reason it is concave is because the facial colliculi are absent. That gives you that concavity. So normal, as you can see, this is the level of the facial colliculi. You should have these two mounds or colliculi, and in HGPPS, these are absent. And because these patients have a horizontal gaze palsy, originally the thought was, well, what do we need for horizontal gaze? We need the abducens nerves. And what are the facial colliculi? Well, the facial colliculi are where the abducens nerve nuclei sit, even though the facial nerves go around them. So probably these patients have absent facial nuclei. Unfortunately, it's not that simple. That is not the case. So it is actually a commissural axon guidance issue and not absence of the nuclei of the abducens nerves. There's also a type 2 of horizontal gaze palsy and progressive scoliosis, which is caused by a different gene, the DCC gene. And this looks exactly the same, with the difference that they also have agenesis of the corpus callosum. So if you have that concave pons, think of horizontal gaze palsy and progressive scoliosis. And if you additionally have a agenesis of the corpus callosum, think of horizontal gaze palsy and progressive scoliosis type 2. Here we have the opposite abnormality of the brainstem. So here, instead of having a concavity, we have a posterior bulge. On the DTI, we can see that those are transverse fibers, which are at the posterior aspect of the pons rather than centrally. This patient presented with sensorineural hearing loss, which is not surprising because he actually didn't have a left cochlear nerve. So this is a case of pontine tegmental cap dysplasia. This is also presumably due to abnormal axonal guidance, similar to HGTPS. And these patients will also have variable cranial neuropathies and extracranial malformations. We have not identified the gene that causes this disorder yet. In addition to pontine, you can also have mesencephalic tegmental cap dysplasia. This is a patient with a tegmental cap at the mesencephalon rather than the pons. These can sometimes be associated with Joubert syndrome and related disorders, or also with fibrodysplasia. I can't say it now. Fibrodysplasia ossiva progressiva. Yeah. The clinical presentation varies significantly. Patients can have normal cognitive function or can be severely developmentally delayed. Finally, we've looked at the cerebellar cysts, we look at the brainstem. Now we want to look at supratentorial abnormalities that are associated with our brainstem dysplasia. And sometimes just identifying the different abnormalities together will give you a diagnosis. So for example, in this case, we have a cerebellar dysplasia, and you can see on the axial images, the normal folial pattern of the cerebellum is disrupted. So we don't have these typical onion ring appearances that we usually have. We have parasagittal polymicrogyria, and we have callosal dysgenesis. And the combination of these three features is quite characteristic for Chudley-McCullough syndrome. Now, there's other disorders where we can have similar abnormalities. So in this patient, we have a dysmorphic cerebellum. You can see the cerebellum is abnormal, is asymmetrically abnormal. The brainstem, also asymmetric. Basal ganglia look dysplastic, partially fused, so we can't see the posterior limb of the internal capsule is an important finding, and the corpus callosum can be abnormal. And when you have the combination of dysplastic cerebellum, dysplastic corpus callosum, dysplastic basal ganglia, and malformations of cortical development, you want to think about tubulinopathies. There's a whole range of genes that can cause tubulinopathies. Most of these are autosomal dominant de novo mutations, so they don't run in families, they just occur spontaneously. So when you have these combinations, think of tubulinopathies. And that already brings me to the end of my presentation. We spoke a lot about the different MR phenotypes. We also touched on the clinical phenotypes and that it's important to see that the clinical phenotype and the MR phenotype need to both be regarded to lead to a diagnosis. When we have access to genetic testing, the genotype can be extremely helpful as well. However, keep in mind that even patients with the same genotype can have completely different clinical presentations. And with that, I would like to thank you for your attention. I would also like to let you know that the next module of our SPIN Fellowship launches on the 24th of October. It'll be on tumors, inflammation, and demyelinating syndromes and emergencies. And we do have a discounted rate for trainees in Africa, where we only charge $50 for all three models together, live and on demand. Thank you very much for your attention. I'm happy to take questions.
Thank you so much, Professor Roberts, for that insightful presentation. It's time for questions and answer. If you have questions, you can put them in the chat box or raise your hand and we'll call on you. Before people start asking questions, most of the images you showed us, were they on a 1.5 Tesla or a 3 Tesla?
So it was a bit of a mix of both. So we have a 1.5 and a 3 Tesla scanner at Westmead. But to be honest, it for these gross malformations, it doesn't really matter. Like you don't need to have a 3 Tesla scanner to identify them. A 1.5 Tesla is more than enough.
Okay, okay. Because we only just recently acquired a 3 Tesla in just one facility in Nigeria in the Federal Capital Territory. So most of
Mm.
the MRI centers in Nigeria are usually 1.5 Tesla.
Yes. So I mean, for small cortical malformations, obviously 3 Tesla is going to be better. So if you're looking for small malformations of cortical development, FCDs, but for the brainstem malformations, they're usually not that subtle. So 1.5 is usually definitely sufficient. Yes.
Thank you. Questions, clarifications. And thank you for the last slide where encouraging giving a discounts for the fellowship for Africans.
Yes, I can show that again if you want to.
Yeah.
I've got a QR code too if you want to have a look. So we had the first module in June, but all those talks are available online. So if you join up for the second module, you will also be able to review the modules before that. I'm just going to move that out of the way. And then the third domain in February 2027. We will also have an in-person meeting in Cape Town in 2027. Won't be in July, it'll be in November 2027. But that will be separate.
Yeah. Not seeing any questions here. Uh, is it that is it that we understood the presentations or we do not understand the presentation? Uh,
Yeah, I hope it wasn't too far-fetched, but
could you put your email, even though I have it, could you put your email in the chat box for people if they want to ask you
yeah,
questions or anything related to pediatric neuroimaging later on?
so I put my email address in the chat. So happy to. Oh, someone put a question in there. So differentiating between cerebellar hyperplasia and atrophy at one point, what frequency? That is a good question actually. So um it'll be easier the longer the frequency is. So the more time between the two scans, the more likely you'll see a difference. It depends a little bit on what the clinicians are doing. So whether they think it's going to have an influence on their management or not. So if they think it might influence their management, if they see atrophy, then you would probably want to have the interval between the two scans a little bit shorter, maybe say 6 months. But there's a good chance that in 6 months you will not see much of a difference. So often these atrophies develop over years.
Thank you. We have about 2 more minutes for questions. You can unmute or put
I
your
think there was a
questions in the
question
chat box.
about the fellowship. So the SPIN fellowship is not only for residents. We do have LMIC rates, but we just have additionally heavily discounted rates for African trainees. But those rates are just for the trainees. For consultants, it's the LMIC rates. Yeah.
Okay. If there are no more questions, at least we have your email in the chat box. I'll hand over to Dr. Ayomide to give the closing remarks.
Thank you very much for the presentation once again. It was a very enlightening one. There's actually a lot for me to go back to, catch up on and learn from the presentation. So thank you so much once again. And with that, we come to the end of this month's monthly seminar series. And thank you everyone for joining. And in a month's time, we'll have another session with another tutor who will be taking us on another interesting topic. So thank you very much, everyone, for joining, and have a nice day.